All right, good morning, everyone. We're going to get started. My name is John Donadio. I'm the Executive Director of the New Jersey Association of Counties, and I'm going to welcome you to, the third in our series of workshops, this one entitled County Health Officers Crisis Containment. I think we put together a terrific workshop this week with county health officers that we're going to introduce in a second. And as I'm sure our audience knows, like the rest of our professionals, I think our county health officers played a vital role in the front lines in containing, controlling, managing the COVID-19 public health crisis. And I appreciate, their hard work and commitment to preventing diseases in general, promoting the public health and safety and welfare of residents across the state of New Jersey. They're going to talk today a little bit about their efforts in data collection, managing test sites, contact tracing, and I think most importantly, keeping the general public informed, which is a vital role that they've played. Before I introduce our panelists, though, just some housekeeping is that if you have a question throughout the workshop, please put it not in the chat box, but in the question and answer box, and we'll make sure to answer it at a timely pause in the presentation. And then also stay tuned for emails about your continuing education credits, particularly the one public health credit that has been approved. We'll make sure to follow up with an email on how you get that credit accordingly. So with that, I am very pleased to introduce our distinguished panelists here today. And I'm going to start with Daniel Regne, who is the Ocean County Health Officer. So Daniel, welcome. Thank you for being here today. We appreciate it. And I'm going to my left is Karen DeMarco, who is the Hunterdon County Public Health Officer. And then last but certainly not least, my friend in Passaic County, Charlene Gungill. So Charlene, it's nice to see your smiling face first thing in the morning always. So welcome. Thank you again for taking the time out of, I know your hectic, crazy schedules that you keep. I appreciate you being here. And Daniel, I think we're going to kick it off with you.
Sure, thank you, John. And really looking at an opportunity, I guess, to share a lot of the work that's been done within public health. And obviously, we're very, very busy at this time across the state. And a lot of times in the past, and I'll go through some of the details with this, but I've always kind of talked about public health being that silent first responder that happens behind the scenes. And everything that you're seeing and hearing through the COVID, that's a little bit more public, and things such as the contact tracing, disease investigation, and surveillance, and pods and mass vaccinations. These are things that have been having conversations and planning and exercising and things of that nature for quite a long time. So I think we have a robust system in New Jersey comprised of about 95 health departments, and they're doing a phenomenal job in working around the clock, 7 days a week at all hours of the day and evening. For this. So just to give a quick shout out to all of them, and appreciation of the work that's being done throughout the state of New Jersey and really the country with this. But just wanted to, I guess, kind of go through and do a little walkthrough of some of the response that's occurring within some of the larger health agencies. We mentioned that there's 95, give or take, health departments throughout the state of New Jersey. But there are 22 what's called links agencies, and just wanted to talk a little bit on what the links model is, and which stands for the Local Information Network Communication System. And if you could just advance the slide one. So LINK stands for the Local Information Network Communication System. It really goes back almost 25 years. Back in about 1997, some of the conversation, the planning began to occur with really the administration at the state health department at that time reaching out and beginning some of that dialogue and conversation, that looking at if there's ever some kind of a large disaster or emergency, and there's always something that's going on in the healthcare, in the public health front, how can we best position ourselves in the state of New Jersey to be able to respond to that, and not only respond, but even the early identification, which is so critical and important. So some of that conversation began to look at the development of a coordinated, robust core response capacity within the state of New Jersey, which incorporates all of the local public health, but provides for lead public health agencies in each of the counties, as well as some of the larger cities that are out there. The system of links is designed as a regional, defined as county and large city. Back in the late 90s, there were actually 24 links agencies, including one in every county, as well as Jersey City, Patterson, and Newark. Right now, Newark still does exist, but the others were absorbed into some of the county function and response. And over the course of time, the planning has shifted to an all hazards type of an approach and perspective to be able to build a core capacity and response that looks at organizing from the local level all the way up to the state. How do you organize that public health response to be able to really respond to almost any type of an emergency, whether it's a hurricane such as Sandy or Irene that occurred not too long ago, what we're experiencing now with the COVID-19. We had an experience about 2 years ago, which I'll talk about in a little bit with measles. And I think some of the other speakers will be discussing some of their experience with this as well. But in terms of the preparedness capacity, includes all the traditional public health resources, but looking at increasing some of the capacity when it comes to epidemiology and health education. John mentioned the risk communication, which is so important when you're looking at an emergency such as COVID and getting the correct and proper information that's out there. Looking at it from the technology side of it, how do you leverage technology to be able to maximize the response? I think we're ever more reliant as a society on technology and making sure that everything is in place to be able to meet those needs and get that information out to the best of our ability. Health planning, looking at where we've been, where we're at, where we want to go, looking at some of our preparedness plans and exercising some of them, the need to implement those plans on a time-to-time basis. Even on the nursing side, evolving some of the nursing component, which is building up some of that public health nursing, and we'll talk a little bit on medical needs sheltering in a little bit as well. And also volunteer coordination. There's a tremendous resource and asset that's out there with the Medical Reserve Corps, and being able to build that up throughout the state of New Jersey to tap into those resources as we continue with any type of a planning or response. If you can just advance. So from a links perspective, in defining it from an administrative code and also statute with Emergency Health Powers Act, under New Jersey Administrative Code 852, it does provide a framework for public health practice standards and performance for all local boards of health and local health agencies in New Jersey. There is a component with 852 that further delineates some of the higher level roles and responsibilities for New Jersey public health links agencies, where they define specialized regional expertise and capacity, where that's explained and defined a little bit further. That looks at some of the core capacities and some of the staffing levels that should be in place to be able to act not only obviously within a local health agency, but those local health agencies should be sharing those resources with other smaller local health agencies within their counties as well, to really try to provide for the most seamless response and planning and things of that nature as you're trying to respond to the many different challenges that come forward on a daily basis within public health. If you can go to the next slide, please. Under Emergency Health Powers Act, it defines links as the lead local public health agency in each county or identified city as designated and determined by the commissioner pursuant to Section 21 of this act. They will be responsible for providing the central planning, coordination, delivery of those specialized services within a designated county or city, and that will be in partnership with other local health agencies within that jurisdiction. So it really is an all hands on deck, and while it's a leading role, doesn't mean taking over all that jurisdiction's responsibilities, but really try to coordinate and get everybody on the same page to be able to move forward with a concerted effort and a plan that kind of makes sense, and it's part of the bigger picture of what's going on within the municipality, the county, the state, and the country. And it's really looking at to really prepare them for and respond to acts of bioterrorism. It could be other forms of terrorism, public health emergencies, threats, and we talked about both naturally occurring as well as could be man-made. It could be anything from the CBRN, if you're familiar with that, the chemical, biological, radiological, and nuclear, and explosive, to be able to delineate that and to have a plan in place to be able to address all of those various issues that we could be faced with. Next slide, please. So over time, I mentioned back in the late 90s, Links was kind of first born, so to speak, and created in a framework from a knowledge perspective and looking at trying to build that out. There was no funding initially, so the thought process and some of the conversation was to look at different funding streams, and there was actually funding back in the late 90s to be able to look at West Nile virus and do some coordination of surveillance and planning and response with that. So at that time, there was some money that was distributed to some of the county links agencies to hire epidemiologists to be able to put in place West Nile virus surveillance and to do some activities from that perspective. From the bigger picture, I think links in and of itself is looking at a couple things in addition to what I've been talking about, but it's really looking at electronic data collection and reporting. The NJIIS, the Immunization Information System, was a big part of that in the early part of the creation in the late 90s. The electronic birth certificate, the death record, even the CDRSS system that's in place right now. That was kind of born out of the late 90s with the Lynx system, and also the Health Alert Network, which many of you may be getting Lynx messages. But the Health Alert Network is only a very small portion of what the Lynx agency does and some of the responsibilities that we've talked about. Numerous exercises and planning, whether it's a functional exercise, a tabletop, a full-scale exercise, or an actual implementation of a plan in response to an emergency, participating in Top Off 3, which at that time was the largest international exercise. It was a multi-state, which included also Great Britain, if my memory serves me correct. But we're also responsible for doing annual exercises and review of those plans and being just making sure that everything is in place. The planning process is critical because I think as you go through and you look at some of the response components that are occurring over time, I don't know if there's necessarily a time that I've taken a plan off a shelf to say, all right, well, what do you do now, like during Sandy or even during COVID? But it's the planning process and the time invested in the planning with all of your local partners to be able to develop that plan that really guides the activities, because there is not a one-size-fits-all with it, and you really need to be fluid and be able to handle the different injects. I would say that COVID has provided more injects than we've ever imagined over the course of time as well. Probably a big changing point from the public health preparedness and the links model was September 11th of 2001. And it really wasn't necessarily the Twin Towers and the planes, but on the public health side, it was more the biological threat awareness that came into play related to the anthrax attacks. I think there was a heightened awareness of the potential for a strong biological attack threat to the United States. There was a big push for smallpox preparedness at that time. There was a big push for developing our plans for strategic national stockpile, having the ability to do mass vaccinations, to do a mass pill distribution of an antibiotic, and also looking to the epidemiology surveillance to be able to have an early indicator of any kind of a biological event or issue that we would be seeing. If there was an act of bioterrorism, what you would most likely see is a surge of flu-like symptoms going to your medical providers, the hospital emergency departments, your healthcare providers, maybe your FQHCs. So we built up a pretty strong system in place to be able to identify influenza-like illness, and that does continue to this day with some of those activities to be able to get ahead of the curve and to learn that there was some kind of an event prior to a much larger impact on that issue that may have occurred within the jurisdiction. And then there was also a shift from all hazards public health preparedness response that really looked at a movement away from individual people and plans to be able to address all types of hazards and identifying the core critical components of a public health response and also where that fits into the collective county and state response so they can all go seamlessly through that system. Now, it doesn't always happen seamlessly, but I think there's a lot of great dedication and effort to be able to move through that process. And I think in this experience with COVID, I think it's going fairly well, considering the challenges that we're all being faced with at this time. If we can go to the next slide, please. So after 9/11, the Centers for Disease Control and Prevention provides some funding to each of the states throughout the United States. New Jersey had received an amount through that dedication to build up all that capacity that I was mentioning. back in 2002, there was pretty significant money. Over the time with everything, I think there's a level of whether it's complacency or priorities begin to shift, that funding does decrease over time. Because if you're not seeing something, especially on the public health side, we're basically in business to kind of put ourselves out of business, if you think about it from a prevention side, because we're trying to prevent all those indicators that in most cases would be driving funding decisions in that perspective. So in 2020, funding to the state of New Jersey and also the links agencies is about half of what it was back in 2002. And with that decrease in the funding, there was that shift in the funding of physicians to a more of a capacity based within the regionalized specialized local health agencies to be able to have an assurance of a response capacity related to what the issue could be related to funding of physicians of like a nurse and a planner, an epidemiologist, a links coordinator, and so on related to that. So we have the responsibility to assure that function at the same time moving forward with that capacity. If we go on to the next slide, please. From an Ocean County perspective, and just looking at it from our lens, some basic demographics within Ocean County. We have a population of just over 600,000. The challenge, and there's multiple within the county in many ways, as all counties have their challenges of planning and things of that nature. While our year-round population is about 600,000, that population doubles in any weekend summertime if you've visited the Jersey Shore. We well exceed 1 million population with visitors and tourist industry. We're comprised of 33 municipalities. We have 2 local health agencies. We service 27 of our 33 towns, and Long Beach Island serves the remaining 6 on the Long Beach Island barrier island. Geographically, we're the second largest county. We're one of the largest growing populations, and that's been like that probably going back to the 20s and 30s all the way up to current time. We have one of the largest senior populations in the country. We have about 100 senior communities. Our senior population is probably about 20 to 23% of the total population, and that's almost double of what the state and the national average is with that. In addition, you would think, like, how could this even be true? While we are home to one of the largest senior populations as a county, we're also home to one of the youngest towns in Lakewood, with a birth rate that's very high and significant. So that provides some unique challenges with that. It's a very diverse population geography. If you think of Ocean County from like your Lakewood brick area down to Tuckerton, and then the barrier islands of your Seaside Heights and Long Beach Island off to New Egypt and Plumstead, it's a very diverse county, and they all have very unique needs from a public health perspective, but also from a preparedness side and planning for all those different activities. Next slide, please. Some of the things that we've been looking at over time in some of the ways that we've kind of implemented some of our plans. We've been a longstanding home to a nuclear power plant, which actually was just recently decommissioned. But we were very active in implementing our SNS plan starting back in 2002 with the KI, which is the potassium iodide distribution, also the replenishment for that. So we did distributions almost on a 3 to 5 year cycle based on the expiration of those potassium iodide pills. So we're able to utilize our preparedness planning to be able to get that out to residents or employees within a 10-mile radius of the nuclear power plant, which was housed in Lacey Township. In addition, looking at some of the increased epidemiological surveillance and review, which has identified several key outbreaks and trends within Ocean County. We identified a hepatitis B outbreak in an outpatient facility in a healthcare provider. Shigella, pertussis, there's been numerous different events over time on the surveillance side. Back in 2009, also with the H1N1 response, we provided about 35,000 vaccinations that were provided through those regional points of distribution, also known as the pods. And also the Ebola preparedness and response with the challenges that had presented and the planning that went into that. We created a task force within Ocean County. We also actually had to enforce a quarantine order in Ocean County for an individual who visited Western Africa at that time doing some missionary work and came back to their home county of Ocean County. So we did actually implement some of our plans with the Ebola as well. From a naturally occurring event of hurricanes in Irene and Sandy, we set up a medical needs shelter during Sandy. We also have some plans related to pets and livestock related to preparedness. A lot of our county, which extends into our neighbor to the west of Burlington County, you have your Pinelands area. Forest fires are a major concern. We have plans in place to be able to handle livestock from the residents of Ocean County and the ability to house them at one of our 3 animal facilities that we have down in Barnegat. Also, the measles outbreak response in 2018 and 19. Obviously, right now with the COVID-19 response, and we try to integrate our plans on an annual basis with our seasonal flu clinic as well, to be able to look at some depth within the agency, from clinic manager positions to even just pulling out some of the response resources that we have to some of our larger seasonal flu sites that we have. Next slide. I think that's all I have at this point. I don't know what your plan, John, is to move on to the next speaker and hold Q&A for the end, or if there's anything at this point, I'd be happy to discuss.
Yeah, I mean, we can open it up to question and answers for you. If not, we can move right into, I think Karen is up next. But I mean, I just have a general question, Dan. Have you, and it goes back to the funding decrease and I guess the number of health agencies. When you hear it out loud, there's 95 health agencies and 22 links agencies in the state of New Jersey. Have you seen a decrease in the local health agencies with the decrease in funding over the past 20 years?
You're talking about from the perspective of our agency budget, or the
correct? Yeah, yeah.
From our perspective, we're fortunate the way we're kind of set up and structured. We have a dedicated health tax within Ocean County that funds the public health agency and the needs within. We review that every year. So we've been fortunate in that sense. We have not seen a reduction with that. Our tax rate has been very stable over the course of the last 15, 20 years with that. But just the way that we're set up and structured, we have not experienced that, but I don't think that's the same in other health jurisdictions throughout the state and throughout the country.
Yeah, but I don't think every county has that tax that you speak of. But I guess when I saw the decrease in funding, I assumed it was an increase in state funding to the local public health agencies. Is that the case as well?
No, this is federal money coming in from the CDC to the state, okay. And that money has been deplenishing, decreasing over the course of the almost 20 years since that came in 2002. So that's the money I'm referencing in terms of that preparedness and the links funding to the links agencies. And there have been some key significant cuts in funding for positions and over the course of that time, which you have to get creative at the local level to continue to meet that need and the responsibilities of standing up a response when it's needed. And now is a perfect example of that, to be able to look at the need that's out there and look at the resources within and around you to be able to meet those needs.
Right. I'm just looking for a way that we can maybe try to secure some state funding to help, the public health agencies. So we can talk after this if you think that there's something that we can do to, pursue that short of the federal monies or, the local tax that you speak of. So, right. All right. So I think we're ready for our next speaker. And thank you, Dan. That was very, very good. I appreciate it.
Actually, Charlene is next.
Okay. Okay, great. Thanks.
Thank you.
Good morning, everyone. I'm glad that you could join us today. My part of this presentation is to give you Passaic County's response to COVID-19, because it illustrates how the funding and how the planning that Dan spoke about in the LINKS program is critical to our response. Next slide, please. All right, so today is day 215 of Passaic County's COVID-19 response. We had our first case on March 14th, And today we already have several cases. Next slide, please. So we were hit hard and we were hit fast at the beginning of this. And we had to really jump into what we do well, which is emergency preparedness and response. As a matter of fact, what we did was on March 9th, I had put together a tabletop exercise. I contacted, in concert with OEM, we contacted all the OEMs, the health departments, all of our stakeholders, the hospitals, and so forth, to come together to discuss what we're going to do in response to COVID-19. So that took place on March 9th. The following week, we had a functional exercise where now that we knew all the players, we were concentrating on what we're going to do for COVID-19. This slide here is just a snapshot of how COVID-19 has affected Passaic County. If you look at the raw numbers, what you see with the raw numbers is that we have always remained in the top 5 counties with number of cases, but that just tells you number of cases. If we were to have the same population throughout the state for every county, what you see is a completely different picture. The picture is that Passaic County has a higher disease burden of COVID-19 if everything else is level. So the state, as of yesterday, I believe, the cumulative index was showing 2,241 persons per 100,000 population. In Passaic County, that number is 3,694. So the raw numbers tell a picture, but the cumulative index tells you how it's affecting this community of Passaic County. Next slide, please. All right. So I mentioned to you that we began with the tabletop exercise. Then we went into the following week to the, I think I'm in front of myself with my slides. All right, so let me talk about this slide, because this slide speaks to the information sharing piece, which is a critical piece in our response. We have found from past responses that it's really critical to have regular and accurate conversations with our stakeholders, with other health departments, and with the governing bodies. And so we began with daily calls with the mayors and their administrators, and then those went to Monday, Wednesday, and Friday with those entities. And what I did was, after I got off the calls with the mayor's office, I had a call with all the health officers, because as Dan described, we have different ways that we bring public health into the community. And in Passaic County, there are 6 other health jurisdictions that need to be in the know with what's going on. Next slide, please. All right. Again, I began with how we responded. So we put together a tabletop exercise on March 9th. I explained that to you. The functional exercise went a little bit deeper, where we were able to look at, do we have MOUs in place? How are we going to respond? Who is going to be responsible for what? What kind of PPEs do we have? How are we going to help each other? How are we going to communicate? All of these things were discussed in the functional exercise. But here is what happened. Between March 9th and March 16th, things had changed dramatically. So whereas the tabletop exercise was in the EOC, which is the Emergency Operations Center, and everyone was packed into the center like sardines, on March 16th, we had to have a virtual functional exercise, because by then we knew enough information to understand that social distancing was the key, in addition to wearing face coverings to protect us. So right there, within 1 week, you could see the response had to change. On March 15th, there was a conference call with the county administrators and county executives, for which my administrator asked me to sit in on. And at that meeting was sponsored by the governor's office. We were told that by the end of the week, we had to set up a COVID-19 testing site. It had to be a drive-through site, and we had to have it set up and ready to go to be inspected by DOH. On the next day, that March 16th, after that functional exercise, my administrator created a team of all the key players. So we had the CFO, we had the sheriff's department, we had purchasing, all of the people who were going to be involved in any major event were at the physical table. And so we started brainstorming on that day. And one of the first questions that was asked to me was, do we have a plan? And I said, yes, we do. I said, this is what we've been planning for all these years. We have a written plan. We have worked with our stakeholders. We have exercised the plan. And we have MOUs or MOAs that are current and functional. And yes, we can do this. So that was a huge weight lifted off my administration when they learned that this is not something new to public health. Over the course of the next couple of days, we were able to reach out to our partner, in this case, William Patterson University. We were able to order and build our site. Again, we used some of the resources from what we received from Links, and also a group called UASI, which provided us with MASH type unit tents. So we were able to stand these up. We got to the site. We worked with traffic control, and we were able to get everything set up for that inspection by DOH. The inspection was also to provide us with training for how to conduct nasal swabs, and also to provide additional PPEs. We were able to begin with a certain amount of PPE, again, because this was part of our planning, but certainly not enough to go for 2 or 3 weeks. The burn rate would have been tremendous, and at that time, it was very difficult to find PPE. So we planned it, we built the site, and on this Friday, we were visited by DOH and approved the site. But here's the next big thing that we had to face. How are we going to man the sites? Who is going to do that? The health departments do not have the resources. We do not have the human resources to do this. So then the conversation was, how are we going to get people to do this when we can't pay them? So we were able to say we have a medical reserve corps, which is part of the Links agency, part of our emergency preparedness planning. And we also went on Facebook Live, and we asked for volunteers, medical community volunteers. We also posted on social media, on our website, and while we're doing that, our procurement team started to look for more PPEs in order to get this thing moving. Next slide, please. All right, so we started the site on March 25th because we were waiting to get volunteers. As a matter of fact, we were lucky that we started so early. We had a total of over 210 volunteers that signed up. Many of them, perhaps about 20 of them, were physicians. Some were practicing, some were retired, some were new physicians that were waiting on their residency. By far, the largest percentage of the group that signed up were nurses, but nurses, EMTs, and people who just wanted to help. They all signed up, and we ran the testing site from March 25th to June 20th. But before we closed it, we had to look at how are we going to continue to test people if the site is closed. So we began looking for alternatives. we contacted Rutgers. They sent us to a provider who could do the saliva test. And so beginning on June 1st, we launched the first ever in the country COVID-19 test at home program, which continues today. Um, and so we set that up on June 1st. In addition, as we pared down the drive-through testing site, we began our mobile testing. We purchased an RV, which is set up as a small clinic, and we started to go into the community to reach people. And so this twofold transition from a drive-through site to at-home and mobile testing. We had two goals. One was to reach people who are unreachable, by going into their communities, but also to reach a demographic that we felt may not come to the testing site, which might be young adults who don't want to seem as if they're concerned, but also older adults whom their younger family members could help them to get into the site to be tested. Those two aspects of our testing continue today, and we've tested a tremendous amount of people, over 7,500 with the at-home testing, and about 1,600 with the mobile testing. Next slide, please. All right. We also embarked on a free food distribution program in concert with the Human Services Department because we recognized that people lost their jobs and people who had never ever been in a situation like this. So the requirement was that they had to be a resident of Passaic County, and it was also drive-through, so they could just drive through, open their trunk, and we put a box of food in there. Next slide, please. This is just showing you that the mobile testing is throughout the county, several times in each municipality. Next slide. This is just an overview of what I just said about the at-home testing and the mobile testing. Next slide. So I think perhaps what I really want to say, I wanted to give you an example of what we have done as a result of the programming and the planning as emergency preparedness. In other words, we were able to launch this huge response in Passaic County, and the only reason we could have done that is because of the planning that we have done over the years. The planning and preparedness, the writing of the plans, the partnering with other entities like the William Patterson Group, really putting a lot of time and vigor and effort into our Medical Reserve Corps, providing them with trainings and encouraging them to stay engaged. This is all part of what we do every day in public health, every day as a links agency, and being that body in the county where all of the municipalities could look towards to know that we have their back. So going into the community with our testing, going into the community with our food distribution, having the at-home testing site, that took a lot of pressure off the local health departments because they knew that the county was taking care of business. And we can only do that as a links agency. Next slide, please. And I think that's it. And I just wanted to make sure that this message was on here because these are the things that we did in Passaic County, in New Jersey, that crushed that curve in April and May. And when you look at our data and you look at the epi curve, you could see a tremendous movement in our numbers as they plummeted. And we have to continue to do that in order to protect the public health. That's my last slide, and thank you. Are there any questions?
Darlene, as we're waiting for some questions, now I think Passaic County, this might be the only such test site in the entire country that does what you're doing. Is that correct?
So it was until last week, Burlington County,
Okay.
embarked on their at-home testing.
All right. Well, that's great. That's great stuff.
Yeah.
And I know that, you know, the links agencies, I mean, you meet through video conference at least 2 or 3 times a week. So, and I know communicate through telephone. So I think that we're hearing that as a common theme with our other county professionals, as well as communicating with your peers, you know, across the state. So that's great that now that other counties are starting to follow a terrific program that you implemented in Passaic County. So I don't see we have any questions, except I got all kinds of boxes on here. So I'm going to turn it right over to Karen. You can get started. Thanks.
Thank you. Good morning, everyone. And thank you to Dan and Charlene for providing that background. And they gave an excellent lead in and background on the links system, which is what I'll be talking about as well, and how that has really aided in terms of crisis containment. COVID-19 is something like we've never seen before. And even in all our drills and exercise, probably couldn't have imagined all the injects that we've seen throughout the last 7 months. In Hunterdon County, we've seen successes and challenges both along the way, of course, but really has been our integrated planning and response, working with our multidisciplinary partners, and the importance of that partnership throughout the years that we've been able to build with our link system. And so I'll give an introduction to that as well and some examples, just as Charlene and Dan did. You can go to the next slide, please. First, I think today you see a real example of the diversity and the differences in the population sizes here in New Jersey. As we know, New Jersey is diverse, and our population, you know, much smaller than Ocean and Passaic and some of our other neighbors to the north. Our population is nearly 130,000. We do have 26 municipalities within Hunterdon County. We have 1 county health department, 1 links agency, so we do not have any local or municipal health departments. And all of that blends into how the response and planning efforts move forward as well. We have 1 Office of Emergency Management that we work with closely at the county level, and also we have 1 major healthcare system or hospital system within the county as well. With our county communications, we have a centralized 911 dispatch center, so all calls from Hunterdon County residents go into a central 911 dispatch center, and that has been invaluable in looking at that as a piece of data in terms of the activity that we're seeing. In addition to the variability in the counties across New Jersey, you also see difference in public health structure. So you have some counties, again, with one county health department, you have others with regional health departments or municipal health departments as well. And even within those structures, the services and the programs and the staff sizes vary greatly, which is really the importance of the links funding as it was introduced in 2002, really provided a foundation or a baseline or standardization of the type of expertise that was within each county and could provide those services. So those links funding early on and today is extremely important that there is that same foundation for all of the counties and residents in New Jersey. So within Hunterdon County, we have the divisions that are listed there. We do have a public health preparedness division. Again, that's generally our links program, and that funding has decreased over the years. So originally there were 9 full-time staff members that were funded with those dollars. Now we have 1 full-time staff member and 3 part-time staff members that work to fill the capacity of all of those who had been there before. Fortunately, we do have all of the expertise that we had gained from those early days. I started as the public health epidemiologist in 2003, so we've seen all of that change throughout the last nearly 20 years and the changes that have gone on through there. In addition to our public health preparedness program, we have a public health nursing division, environmental health, mosquito and vector control, solid waste and recycling, and weights and measures are also within the Hunterdon County Health Department. So when we're working on our drills and our exercises for our links grant or for other preparedness exercises, it's basically all hands on deck for those pod exercises, medical needs sheltering, you know, it's pulling staff from those other areas. When an emergency lasts 7 months, as we've seen now, that all shifts because we still have all of those other programs and services that need to be maintained. So particularly with COVID, as we've seen business closures, restaurants changing their operations, we've seen an increase now in the housing market and the impact on what that's done with our septic review plans and all of those pieces. So the twists and turns along the last 7 months has created challenges in how we had planned to use staff in those short-term responses and how that varies with this long-term response. So continuing to be able to provide the services and respond to the needs of the community while also responding to COVID-19. Next slide, please. So Dan and Charlene provided some background on this as well. I think that the foundation that's been set with public health and the way that we've had success with responding to COVID-19 is really looking at the work that we do in and out each and every day. As Dan mentioned, we're kind of the silent first responder in the background. We're always working to mitigate or to reduce any health risk to our community. So in that way, we are similar to first responder agencies. We want to reduce that threat, and the threat that we're trying to reduce could be disease, could be environmental, could be pollution, could be all of those issues. In the state of New Jersey, there are over 70 reportable diseases in the state of New Jersey. So that means any of those 70 diseases need to be reported to the health department where that individual resides. There then is a New Jersey communicable disease chapter, which really functions as a playbook. Depending on how that disease is transmitted, what the incubation period is, really tells the health department what action do we need to take. Do we need to conduct contact tracing? Do we need to encourage those who had close contact to take antibiotic to keep from becoming ill? Those types of actions. So that is work that is done each and every day by all of our public health nursing divisions or epidemiologists. Before COVID, we have our foundation and our baseline of expertise in that area. The other areas that has really been enhanced that Dan mentioned as well is with the creation of the LINKS system was surveillance of other health indicators within the community. So looking to our long-term care facilities, our schools, our emergency department, what type of activity are we seeing? Are we seeing high absenteeism within our schools? Is that an indicator of the beginning of flu season, for example? So always looking at those trends and thresholds throughout the last 20 years to really bolster the information that we have so that we can respond faster. Also throughout the years with LINKS communication or the LINKS grant, we've worked on risk communication exercises, whether it's preparing press releases or talking to the media. Again, I think the challenges of COVID-19, the amount of information that has been out there and with social media, how all of that shifts so quickly that, some of the principles we're taught is be first, be credible, and be right. And as we all know with the current environment, it's very difficult to be first because if someone has their phone or a Twitter, then that information is out there and it's out there quickly. So, providing information and making sure that accurate information is out in the public or to our key stakeholders has been extremely important. Again, we've worked with our partners to provide medical material management, so our point of distribution exercises, and that's some of the planning that we're doing now as we look forward to a vaccine. And you can go to the next slide, please. So again, we have all these years, 20 years of public health preparedness planning and working with all of our partners and many of the programs that Dan and Charlene have mentioned as well in terms of medical needs sheltering, outbreak responses, measles response, Ebola preparedness, those different areas, which I'll mention a little bit later on, is we have our plan, we have our binders in all of these years and how we would like to see it go. And then as we know the twists and turns that we've seen with COVID-19, providing challenges that we couldn't have imagined. So the pieces that I'll touch on today is how we manage the rapidly evolving disease information and how we communicated the needs to our key stakeholders and kept in contact with them and responded to their needs. And again, the challenges of a long-term response. You can move to the next slide, please. So the first thing we did with rapidly evolving information, again, I talked about that disease playbook or the communicable disease chapter that we rely on whenever we're responding to a single case of disease or an outbreak. What are the next steps that public health needs to do to contain that outbreak, to ensure it doesn't spread to other individuals, other populations, or to track what that source of illness was, whether we're talking about, again, a GI illness, a GI outbreak in a long-term care facility, or if we're talking about romaine lettuce and E. coli. Trying to track that source of illness. And this is a tough slide for you to read. But so the first thing that we did is really to handle our internal communication and develop our incident command system specific to COVID-19. So the first thing that we saw is how quickly that information was changing. So unlike responding to measles or bacterial meningitis, where we know how that disease is transmitted, information, as we all know about COVID, has been changing weekly, daily in some circumstances, so that we we wanted to make sure that we had a handle on that information. So these are the groups that we've developed who are really the responding agency for the county. And it involves our public health nursing division, who were responding to reported cases, conducting contact tracing, working in groups or facilities where there were outbreaks, keeping those line lists and communication, and also responding to after hours calls. So that had been a challenge too that I know my colleagues across the state and across the country have dealt with as well, is our public health nursing division or our staff was now moved to a 7-day work week. So they were rotating to make sure that they could respond to those after hour calls. And they continue to do that now as we start to see an increase in cases in the county. We developed an information hub. So with the information that was coming out, whether it be from the CDC, from our state health department partners, or from other county agencies or other departments, we wanted to be able to gather that information, and each staff member couldn't be on every conference call or participate in that. So we have a couple key staff members who do participate in each of those conference calls or gathering that information, and they summarize that and give that to the group as well. They were also, that information hub was our primary in pushing information out, whether it be on Twitter, Facebook, or also on our website, and responding to inquiries as well. Sort of our go-to person if we got a weird call or question, we could go to that individual or team. Our public health preparedness is functioning in contact tracing, as well as specimen transport, working with our MRC to make sure that they are assisting with contact tracing, and also with our drive-through test operation as well. So that management of our medical reserve corps comes from our public health preparedness division as well. Now, as we're looking to vaccine planning and those efforts, that is primarily under our public health preparedness division as well. Health department administrative needs. So as we've seen throughout the pandemic, there was remote work that was being conducted. There were IT needs. The increase in staff work resulted in challenges with payroll or tracking that. So we do have a primary team who are working on those administrative needs within the health department. And then also a key piece of our response in Hunterdon County has been our partnership with the Office of Emergency Management. About 4 years ago, we integrated a staff member between the health department and our county Office of Emergency Management. With our planning for Ebola, we saw that there was common mission and a link that could be and should be created there. That also aids us in responding to the needs of our first responder agencies. And it also lends to us being able to lean on their area of expertise in terms of emergency management, and really can bolster and strengthen our response as well. So with our, the arm of the Office of Emergency Management, there was the activation of the County Emergency Operations Center. Again, he and his staff coordinated the ESF lead, and also working with our first responder agencies. Also with our emergency management, they were key in managing our warehouse and our PPE requests and other material requests that were coming in from our medical care providers, our long-term care facilities, and our first responders. So very quickly, we created a process where we were able to provide personal protective equipment to those on the front lines who needed it. And still today, we continue that operation and providing personal protective equipment or other materials as needed. Can you move to the next slide, please? So something in our communication as we were communicating with entities is really establishing our key metrics and standardizing the information that we would be providing regardless of the group that we were speaking to. So really looking at our daily case counts, and as all of the health officers on the call know, that there was a lot of demand for that information, and how many cases were being reported per day, how many per municipality, and there was some variation in that. So initially, the state was releasing the municipal-based information, and there was some back and forth, and now there is not that municipal release of information in terms of specifics to cases. So I think also when you're looking at smaller communities, such in Hunterdon County, smaller municipalities, it's important to ensure that you're not violating HIPAA or releasing information that could identify the individual who has been affected. So that is something that we have released on a daily basis. It's simply the case count, but without any additional personal identified information to protect that, the confidentiality of our cases as well. I think with all of that, you want to garner the trust of the individuals who you're interviewing. through your case interviews and contact tracing, and protecting that information is extremely important. Again, we also are looking to our 911 dispatch data. So we were able to see the number of calls for medical assistance in individuals with respiratory illness or illness consistent with COVID-19. This was building on a system that we had developed in response to Ebola in 2014. With county communications and public safety, we were able to create an alert and also included our Hunterdon Medical Center on that alerting system as well. So whenever there was a case with Ebola, it was anyone who had a travel history within 21 days and symptoms consistent with Ebola that would trigger a text alert to a task force and a group within the county to know that there was someone who was being transported that had symptoms consistent with that. So we tweaked that to indicate if there was someone who had symptoms consistent with COVID-19, not only giving our task force a heads up, but also for the first responders to ensure that they were using the correct personal protective equipment. We also spoke daily with our hospital partners in the emergency department and looking at their admission data. Also those daily briefings along with the Office of Emergency Management and their emergency management coordinator, infection control practitioner, and other leadership, we were able to gather real-time information when we started conducting those in March. We have scaled back from those daily briefings, but we have scaled up in response to some of the facility related outbreaks we've seen recently. Again, the rate of transmission, as these data points were introduced from the State Health Department, we began including this in our briefings with our key stakeholders that we were speaking to as well, and also with the COVID activity level based on region. So as we've had data points or information that has been released from the state side, we share that, and this tends to be our sort of our snapshot, our daily situation report on what we're seeing and how those cases may be rising. And as we have seen within the last 2 to 3 weeks, we have seen an increase. In July and August, we saw a bit of a lull, but in looking at this data daily, we have seen an increase in the last 2 to 3 weeks. And you can move to the next slide, please. So again, communication with all of these stakeholders has been key, and really a large focus of our response, ensuring that people have accurate information and know who they can reach out to if there are specific needs. So in keeping in communication with our county freeholders, administration, other county leaders, our department heads here, we had frequent, if not daily briefings with them, providing information on what the situation was with COVID and what our mission was at that point, whether it was creating a test site or adding staff to be able to respond to contact tracing as well. Again, with our communication with internal staff, we created our key group within the health department, and we provide daily reports to that group in terms of, you know, the information changing, whether it's the long-term care facility guidance, all of the executive orders that have come through, all of the changes that have played out with the changes in guidance. We want to make sure that our internal staff has that as well. So sharing that on a daily basis. Our first responder community, I think also providing information on the personal protective equipment and the best practices and information for first responders, but also in responding to case concerns or urgent needs, or you know, you think there's an exposure, you need an answer now. I think a lot of that communication that has come through is providing, sifting through and collating and providing the information that we have at this point, but being able to respond to those case specific needs as they've come through in the last 7 months has been critical to make sure that we can provide a quick and timely response and accurate response for them as well. Our medical care providers, again, daily briefings with our healthcare system, but also in providing health alerts or links communication messages to them as well. Long-term care facilities, in response to outbreaks, we've communicated with them multiple times per day, but I've also had regular conference calls with that group as well, and email chains. Residents, I think we've created a framework where we're able to respond again after hours, but also with our risk communication strategies and responding to the needs that are there. One that I also did want to include was our communication with our public health colleagues or with our other LINCS health officers. So as Charlene and Dan mentioned, with the staff that we had back in 2003, the creation of a health educator, risk communicator, one in each county. a public health epidemiologist with one in each county. Having that foundation and that standardization of staff also creates linkages to having a clear picture of the situation. So serving as the links epidemiologist, there would then be a chain of communication between all of the links epidemiologists. Part of the challenges, I think, with COVID in the last 7 months is we are all so entrenched in what's happening within our individual counties that we don't have a handle on what's happening on a daily basis, surely in Passaic County or even in a neighboring Somerset County, in terms of, what questions are they getting, what types of challenges have they have, what current outbreaks are within facilities. So I think creating a stronger network there is something that we've done at the Links Health Officer level by having weekly communication, which started a few months ago and has really been invaluable in terms of just keeping our finger on the pulse of what's going on throughout the state rather than only in our own county. So as we look to create those linkages and recreate the linkages that had been there in terms of communication, just learning from each other. So if there's an outbreak in one facility, what types of tactics were learned there, and take those best practices from one another and be able to implement them in our own jurisdictions. And also schools, I'll touch on that in the next slide as well. So in terms of our school community, we've had regular communication with our public schools since spring. So when the cases began to rise and in discussions if there was going to be a school closure or not, we kept in communication with them. After schools had closed in the spring, we did see some cases related to those school communities, and then working through, that gave us a sneak peek of what we're now experiencing in the fall in terms of a case in a student, conducting contact tracing, the district communicating with the entire school population, the influx of calls to our department, and how to navigate that and how to manage that increase in work activity. We kept in communication with all of our school superintendents and school nurses, and also our directors of special education throughout the summer months as they looked to create graduation planning or celebrations and reopening planning as well. So with each of those groups, the school nurses having concerns about personal protective equipment and other measures or activities that they would be conducting there, when to exclude a student, and that having the most up-to-date information at that point throughout the summer so that they could plan ahead was crucial as well. Working with our special education directors from other districts, special education classrooms, depending on the school or the district, poses its own challenges in terms of what the student needs are, their inability to wear a mask, their need to work closely with those students, and what that meant in terms of controlling disease spread within that classroom or within that school. So speaking frequently with them. I think at the point that we were providing information, there was concern about having the most up-to-date information about exclusion, what type of PPE should be used in that clinical setting, really an outpatient clinical setting if you're looking at a school nurse's office. So ensuring that we could provide them the most up-to-date information, but also at the same time, being able to say that this information might change or that there might be other guidance that's going to come forward from the CDC. And that's what we've seen, is that we've been communicating with these partners, and then there may be a shift or a change. And I think when having our communicable disease information, we're not necessarily used to that. We're used to having that hard and fast rule and being able to provide that. And one of the twists with COVID-19 is being able to be forthcoming about just not having the information and ensuring that this is the most up-to-date information that you have at this time. So what we did in Hunterdon County is that we worked closely with our health departments in Sussex and Warren County to ensure that all of the school districts in the region were using the same foundation in terms of procedures and protocols. And then we worked closely with them to help interpret the New Jersey Department of Education guidance and the New Jersey Department of Health guidance that has come forward. And as we have seen school-based cases and transmission within Hunterdon County, and each of those situations is completely different. So making sure that the schools have the linkage to the health department so that we can then do that case interview and conduct contact tracing and make quarantine recommendations from there. And there are a lot of detailed questions that aren't necessarily within the guidance documents that have been released. Much of the documents say to consult with your local health department. So making those judgment calls and working with the schools closely. What we have done in order to address the influx in phone calls, from the school community is we've created a school-specific hotline with our public health nursing division so that there is a dedicated line for schools so that they can receive a response quickly. We've also created a school-specific email address, and as we've received questions, we've created Hunterdon County frequently asked questions for our school population as well, since they are very, very specific in their questions. And still, you know, the information continues to evolve. At this point, there are schools in Hunterdon County that had a hybrid model, and many of the parents are now asking to have their children come in person, even though they had selected virtual. So the challenges that are faced there in terms of not maintaining social distancing, what does that mean? And all the challenges that come along with that. So that piece continues to evolve, and we continue to work with school superintendents and speak with them weekly on a conference call, and then also respond daily to the school-specific concerns. And you can go next slide. Thank you. And just briefly, I know we're getting close to time, or we're over time a little bit here. I just wanted to make mention of some of the pre-COVID preparedness activities that we've conducted in Hunterdon County. I've touched on some of them already. Is really with a small staff, I like to say we're a small but mighty staff here at Hunterdon County, is really leaning on one another's and relying on each other's subject matter expertise, and bringing the team to the table to really develop those plans and continue to drill and exercise. So our previous activities that have really lent to our success with COVID-19, again, the Ebola response planning really brought together key players from our medical center, EMS, 911 communications, OEM, public health, and really aided in the communication that we had set up there. So that communication platform has also enabled us, from our Ebola preparedness, we have a mix of volunteer and paid staff EMS agencies here in Hunterdon County, and some EMS agencies were not willing to respond and had voiced that to a case of potential Ebola. So from those who had the interest and ability, and we created a communicable disease EMS task force, which we have then enhanced to provide them with information well beyond Ebola, including measles, and now COVID-19 as well. We've conducted tabletop exercises, planning, PPE, assessment of what they have, and ensuring they know how to don and doff PPE and how to acquire it as well. So also working with our law enforcement agencies, as again, the state executive orders that our department is receiving questions about, restaurant executive orders and all of those pieces, sports, all of that comes back to the health department with all of those community inquiries. So ensuring that we have a close linkage with our law enforcement partners, whether locally or with our county prosecutor's office as well. And they've been included in all of our frequent briefings. The health department has also been engaged in hazard mitigation planning for the county, and back about 4 years ago, we did include infectious disease as a hazard. So I think also lending on what Dan had mentioned is we moved away from just disease emergency response to more of an all hazards response. And I think we've drilled that and exercised that here in Hunterdon County as well, as looking at that infectious disease threat, whether it's Ebola, whether it's some strain of influenza or COVID-19. Also looking at, in a storm response, power outages and the threat that could cause with consuming spoiled food and the issues related to that. So really looking beyond that traditional lens. Also, our hazardous materials response program is a shared operation between emergency management and health. Again, just another area where we've collaborated and we've been able to build on that for COVID-19. We've worked closely with our schools and law enforcement and other community agencies in a mass violence prevention and response program that has been in place for about 2 years in Hunterdon County. So again, just those linkages and those partnerships that have existed throughout the years have become extremely important as we're navigating COVID-19. And with our medical center as well, there's a number of collaborations there, including our Partnership for Health, and other agencies are involved with that as well. You can move forward. So again, as we've looked at the collaboration that we've had, is really looking at that data sharing and also in grant funding collaboration. So as there is increased funding for COVID-related activities or the information that we would need, and looking to our public health partners to be able to gather that information. Last year, it was a bit ironic. We had received grant funding to develop the Communicable Disease Council, which was strengthening our county preparedness and response related to communicable disease. And we were just beginning to work with that group when COVID-19, I believe one of our first meetings was in February, but we've been able to utilize that grant funding, and that had also created that foundation, or enhanced the foundation of the partnerships that we have, and pulling together multidisciplinary partners to focus specifically on communicable disease. So that was well timed that we were able to pull that group together. Other areas where we have collaborated with our law enforcement partners, schools, and medical community is our opioid fatality review teams, and also in suicide prevention programs. So in each of those areas, it comes down to relationships and partnerships with your agencies, and knowing who you can go to in a time of emergency. You can move forward. In terms of the challenges of the long-term response, I think that in all of our drills and exercises, it was there would be a scenario, and there were cases of plague, and we would need to drill providing medication or pills to a large amount of the community, and then the scenario would close. So as we see, this is 7 months and counting, and twists and turns along the way, and the challenges that have come. Our foundation and our planning has certainly sustained us and prepared us well, but we also are just navigating all of the changes here. And a piece of our plans that had always been in place is to keep in mind the staff that you're relying on may be affected in this emergency. So that was something, when you're looking at your team, make sure that you have backups for them. Have 3 backups for all of your staff members. Well, in this situation in COVID-19, it's not only that our staff are temporarily affected, no one has been unaffected by COVID-19, and the challenges that brings with our staff as well as the community, and really the urgency that comes with every phone call from a community member or from a partner or from a facility, that every phone call and email has that urgency to be answered, and really maintaining that for a 7-month period. So this isn't simply a storm response or a short-term, long-term care facility GI outbreak. And I think at one point with our staff, it's being realistic. Like, how long can you run on adrenaline, and make sure that you're pacing yourself, and really setting our priorities and recognizing the mental health challenges that come with digesting 100-page documents, and how you're synthesizing that information for your partners as well. So I think our staff have done an incredible job. Our subject matter expertise, our public health nurses, our health educators, incredible work being done. But I think also just taking a step back and making sure that we're pacing ourselves and setting those priorities as we move to the next phase. I think the cycle that is in front of you on the image there, just this continues to cycle throughout these 7 months, is that we are constantly preparing and responding. So as we continue to respond to case counts and outbreaks, we will then be preparing for vaccine, and that is continuing throughout. And really, again, focusing on our staff and ensuring that they're getting the rest that they need in order to be able to respond. And I think that you can, one more slide, sorry. So again, the continued response and preparation, again, that continued cycle, that it's evolving information. So still today or next week, we're continuing to gather information on what our new mission is, or what our priority is in terms of the response. We're starting to see growing case counts, outbreaks and clusters, whether it's within school communities or facilities. We're beginning to see that now as we are entering the fall months. Again, we're looking for vaccine planning. So as we shift our staff and start to focus on that area, what that means, how we're gathering that information and making preparations now. And the importance of the foundation of that strong public health structure. So the funding and the structure that is in place today is different than it was in 2003 and 2005. And the importance of continuing that preparation and bolstering that so that we can respond to emergencies such as COVID-19. And I think I'd like to hand it to my colleagues here if you have anything to add at this point.
Charlene or Dan, anything else you'd like to add?
I would just add one thing, and I think it was Karen that mentioned it was the standardization, the planning that we've been doing for in excess of 20 years. What's nice with it is that there is that standardization, so that that core response capacity is set within each county, and then it's customized to the unique needs within that county. So we all have that baseline, so to speak, of what we're able to do, and then we customize it based on the unique needs within that county and the municipalities that are comprised within that county. So that's the one thing I think that it's, you know what you're getting based on the CDC grant deliverables and the state of Department of Health grant deliverables as well, because they're all kind of built in a similar way, so we can lean on each other in that capacity. And the only other thing I would say is on the messaging, which is so important when it comes to something like COVID and something else. Social media, this is probably the first emergency that social media has played a significant role in very challenging, at least from our perspective, to be able to dispel rumors and get the proper accurate information out to the community. And if somebody heard something, like how do you respond to that if it's not true? And so I think just getting that information and trying to squash those rumors and misinformation that's out there in the community, so your residents have the proper information. And so social media has played a huge role with this, and certainly one of our after actions that we've been kind of bringing into play along the way over the course of the last 7 months, will be a huge component moving forward in our planning.
And I just like to add that I think that this COVID especially has demonstrated to us how important it is to know who our partners are, who our stakeholders are, and to nurture those relationships, because when something like this happens, it really, you need all hands on deck, and people are able to help you to make the response better. And if you don't have that, it's hard in an emergency to create these new contacts. So I think what we've been doing over the years, looking at our fixed facilities, looking at partners, training our MRCs, I think those are critical things that we could do better on the county level and as links agencies, because we can respond to larger populations, crossing different political boundaries within our counties, and help more people. During our drive-through sites and even at our mobile testing sites, though we always say it's for Passaic County residents, we get people from other counties as well. But it is always surprising to me to see where we're having the testing site and where people are coming from. And I think that's critical, because we can have a site in the most remote part of Passaic County, and we get residents from our most densely populated municipalities. This only works as a links agency because of who we are. If it were that local health department, it would have been more difficult for them to handle some of the testing, because they would have to deny so many people. So I think creating the links agency, giving us a directive to serve the entire population, has been a very effective tool in our response to COVID-19.
Great, thank you, Charlene. And on behalf of NJAC, I look forward to working with you and the links agencies and helping foster the important work that you do. I thought this was a fantastic discussion. It was educational. It was informative. It was certainly timely. I'd like to share your PowerPoint presentations on our websites for folks who want to go back and do some research and review what you spoke about. But again, it was terrific. I thank you again for your time and all the hard work that you do on a daily basis, but also your hard work for putting together this presentation. Also want to thank Angela Wolf for making sure that this went very smoothly again. So thank you, Angela, for your hard work as well. And since we are a little bit over and there doesn't look like there's any questions. I just want to say thank you to everyone that participated today. And again, thank you for just an outstanding panel discussion. I appreciate it a great deal. And again, look forward to working with you. And stay tuned next week for a workshop on procurement. So it should be another very good one. So thanks again. Have a good day.
Thank you.
Thank you.